Healthcare is changing, and Dr. Nancy RN is here for you. The topics are many, but each program stands on its own with 3 key action points for you to learn. Your guide to a healthier you in a changing world. Dr. Nancy RN.
Welcome to Dr. Nancy RN, Healthy You, Healthy Nation, Healthy World. I'm Nancy Valentine, PhD and registered nurse, and this program is dedicated to you, the healthcare consumer. And there's been a lot of new programs that you've heard about, and today we have a wonderful guest that's going to talk about one of these programs, and I'll introduce Dr. Joseph Greco in just a moment. But the title of our show today is going to be talking about the patient-centered medical home, the promise for transforming delivery of primary care in the United States. And Dr. Greco is really going to help us understand what that means. So let me introduce you from his background, which is very impressive. Dr. Greco first went to Notre Dame University, where he got his baccalaureate degree, and then he went on to Jefferson Medical College. When he finished, he did his residency and has really maintained a practice for his entire career at Bryn Mawr Hospital in Bryn Mawr, PA. He is the program director of the Bryn Mawr Family Practice. And he's going to be talking with us today and educating us about this new buzzword, the patient-centered medical home. Joe, thank you so much for being with us. You have an outstanding reputation at Bryn Mawr Hospital, and you are a transformer. And so we want to hear about this transformation. So I think that to set this up so you can understand a little bit about this, the reason we hear so much more about the patient-centered medical home is that with the Accountable Care Act, we are really looking at more people being covered by primary care. And we also, as you know from reading the newspapers, are anticipating a lot more Medicaid patients being covered. But this is not really just for that population. And as Joe will be telling us today, the whole concept of coordinated care and many of the elements that we will be talking about today are really not brand new. But with the Accountable Care Act, it really has resurrected this and has really now brought it into the forefront. And I think with that, Joe, tell us from your experience, since you have dedicated your entire profession to primary care. Tell us about how this has evolved from your perspective.
Yes, thanks for having me, of course, Nancy. And I will say that over the years, it was simpler earlier, taking care of patients and going through, making sure that you're doing everything. And then as things evolved, it got to be more difficult to make sure that you're checking everything that everyone's going to be checking you're doing. So for a short visit, have you asked about domestic violence? Have you screened for osteoporosis? Did you make sure the immunizations are up to date, et cetera, et cetera? And it became increasingly difficult to cover all the bases in a short period of time when you're with a patient. Secondly, you started to have to see more patients in a shorter amount of time and be more effective. So I think there's been an overall drive to increase quality and effectiveness and patient safety and think about that in a cost-effective way with good outcomes for patients. So something had to change.
Now, would they have changed, do you think this would have evolved naturally if it had not been for all the moving parts of the Accountable Care Act? Or do you think that the Accountable Care Act, as I just mentioned, really did push the envelope, so to speak, on this?
I think that the new legislation, it kind of accelerated the path of this, but it really is something that needed to be done in order for us to take better care of the population. And it really didn't matter what their insurance is or who the president is or who dominated Congress, that this is something that the community needs. And doctors and healthcare providers, administrators and insurance, there's many stakeholders looking how to best take care of a community. And these pathways were set in motion long before some of the recent politics have come into play. And with these new things, it actually has allowed us to be a little bit more verbal about saying we need to do this for patients and having more support for doing it.
Right. I think, well, that's really important, I think, to make that point. And part of why we were having this series is that we want to really translate some of these new changes so that you will understand as a consumer how you play a role in this as well. So tell us in terms of the ABCs, so to speak, of patient-centered medical homes. What are they? What are they going to look like? Who's going to go to them? I mean, again, people really don't know what this really means for them.
I think to acknowledge what you're saying, a lot of patients, when they hear the phrase, have been a little put off, sometimes frightened, because the nomenclature sounds like a nursing home or a funeral home, and they don't want to be put in a patient-centered medical home. And while it's a little comical, I could understand what patients are fearing. And the truth is, it's really your doctor's office, but it's transformed. And it is a way to deliver care, coordinated care, across the continuum for the patient, wherever the patient is at the time, whether they're living at home doing fine, acutely in the emergency room or the hospital, perhaps after in a nursing home or an extended care facility, and being able to coordinate that care through specialists wherever they access the healthcare system.
So you said earlier, just in terms of the whole evolution of healthcare and of medicine, you were expected as a primary care physician to do so many more things, the checks and balances. Now, those things haven't gone away, and you're talking about having even more services. What's going to really allow that to happen? I mean, what are going to be the support systems that really permit the physician to be more effective in that role now that we do have it anchored in this term, medical home?
Well, there are many factors that are helping us to do that. And one important concept is a team approach to care, where everybody really works at the height of their credentialing, so that medical assistants, front office staff members, nurses, nurse practitioners all take part in delivering the care to the patient to the height of their credentials, so that the doctor isn't doing everything but working with coordinating the team and leading the team to provide the patient-centered care. So that's one concept that is a different bit of a workflow that supports efficiency with the patient. Another, obviously, is the onslaught of the electronic medical record, which has been huge, because that has allowed us to not only document information, but to sift through information that we have about our patients to identify in a proactive way the patients who need our care, who perhaps are not accessing it the way that they ought to. So I think that's another big thing that has changed. And lastly, really is the way things are reimbursed and valued with the different stakeholders, for instance, insurance companies, employers, so that they're going to have to shift away from really a productivity model of reimbursing physicians for seeing patients and look more at outcomes of how well are you controlling somebody's hypertension or diabetes, how well are you doing with immunization rates and other quality measures that all physicians should pretty much agree are important, universal goals that we have for our patients.
Very well put, but let's sort of tease out each one of those, starting in reverse. Let's start with the electronic medical record. Are people going to have access to their own medical record, or are they going to be carrying a little version of their medical record in their pockets? When you say that there's going to be a better infrastructure of record keeping, and it will be electronic, just tell us how people will experience that.
So actually, to be certified as a patient-centered medical home, there are a number of elements that your office has to demonstrate the ability to provide patients certain types of care. And one element that is required is the patient's ability to interact with you electronically. And there are a number of ways that your individual office can do that, and a number within that patients can choose themselves to use to access their doctor and communicate with their doctor. But I really don't think any patient is going to be required to do anything that they're not comfortable doing. Again, we keep emphasizing this is a patient-centered. So we have to keep the patient on the moral high ground as we make these changes. So to answer your question more specifically, when a patient communicates with the doctor, there'll be an availability for them to access and send a encrypted message to the doctor, and the doctor can respond to that, and they could have a dialogue, kind of like a text message conversation on a phone, but protected, so that that information can be acted on. Or they could let the front office know that they need a referral or a medication refilled. And if it's appropriate, it can happen. If it's the doctor needs to see them, the front will say, you need to come in and discuss this with the doctor. So I think most of it is going to eventually be web-based, but really protected, the same way that ATMs have protection for privacy, and people are used to using that kind of information very quickly. And I think there's an extra degree of caution around medical information, which is important, but there needn't be the fear of it that I think some people are afraid of somebody looking into it and finding out your private information.
Right. Well, I think that's very important because of all the privacy laws. It has to be something that, again, you are talking about something that will give us maybe more access, more ease of use, more of a sense of connectivity with your doctor and your team.
And actually, when you, as the doctor, fill out the record and complete their visit, one thing that we do in our office is we generate a visit summary that tells the patient, these are the diagnoses that we addressed today, these are the medications that you're on, and this is our plan. And it gives a chance to clarify and review things, and we give that to the patient. So we've gone from electronic to handing them a piece of paper. As we become more proficient in this, the patient can probably access that summary sheet in a way that is user-friendly. So they're not going to be reading their medical record and having to sort through a lot of medical jargon. There has to be something that's translatable and meaningful for the patient to understand when they look up their labs, when they receive their x-ray information. And we've started to pilot some of those processes at Bryn Mawr Family Practice.
I think that's exciting because as each person has access to their medical records by being able to look at your own lab values, to see the summary of what that visit entailed, it really helps us as consumers to understand what those numbers mean. So there's going to be more education so that you can track on your numbers, so that you know what you have to do in terms of your follow-up and follow-through in order to really achieve what Dr. Greco was saying are the outcomes. So I think that's all good news. But it does mean that people are going to have to be more knowledgeable about what's happening with them.
Yes, in fact, to be designated at a patient-centered medical home, as a patient-centered medical home, you need to demonstrate as an office that you're educating the patients about how to take care of themselves. So that if someone were to stop someone when they're leaving your office and say, do you have high blood pressure? Yes. Do you know what you need to do to take care of your blood pressure? If a patient leaves our office with high blood pressure and doesn't know their role in maintaining a good blood pressure, then we've really failed them. And again, it's about being centered around the patient or their caregivers so that they know what to do to stay well.
Right. I think the other point that you made about outcomes, even just from a business perspective, is really important because people remember, if they're over 30, the difference between going to a doctor's visit and spending some time with your doctor and having maybe a full discussion about something that you were concerned about. Then when managed care came along, it was like a production line. You only had so much time and that was it. You were in and you were out. So I think that what you're saying is one still has to be productive, but there will be a different emphasis by the insurance companies on outcomes. So if it does take a bit longer, if you get the outcomes that you're looking for, the way the reimbursement will work will be to reward those outcomes, that they are achieved. And that again is a partnership between the primary care physician, the team, and you as the consumer. I mean, to get outcomes, it takes everyone.
It does, and the insurers are really looking at dividing up and making a mix of their reimbursement to not just be productivity-based and service, fee-for-service, but combining value-based care and management of a population of people and having some upfront administrative costs supplied as well as some wraparound services. So they're trying to assist the doctors in achieving this level of care because they see the benefits of having their population of insured patients managed in this type of care setting.
Right. Well, part of this, the mission of this show is really to address those patient engagement elements. You are the consumer, you are the patient, you have caregivers at home, your family. It's all around engaging you by having you understand the inside of how all these different changes are going to work, and then your very pivotal role in how you will play a very clear and decisive number of steps, really, again, as we said, to achieve those outcomes for your care so that you can achieve health and wellness. Now, let's go to your first point then, and that was different members of the team, and how you said people are going to be working to the full extent of their training or their license if they are a licensed healthcare person. So let's just use an example, nurses, for instance. In some doctors' offices, there aren't that many nurses that I've seen. I mean, there are usually the technical people that do the sort of the ramp up. You know, they help you get settled. They take your blood pressure, your weights. Do you see a role evolving for nurses? How do you see nurses really operating in these medical homes?
I think a great need is the care coordination piece, and that is something that nurses really bring very well to the table. Knowing how to interact with the patient, turn around and explain that to the doctor, get back to the patient, translate to the emergency room, make sure all the T's are crossed and the I's are dotted, and nurses are very careful at doing that. And they do it in a compassionate way. So I think there's something about that profession and that role that is crucial. You maybe, in certain offices, may opt to have a nurse practitioner do that, but nurses definitely are going to play a role in care coordination.
So I think that that's very important, again, to translate what is care coordination in a primary care setting. So I'm going to ask you to just think off the top of your head of a typical case that would come through the door. Tell us what, with the nurse being there, the kind of care coordination elements that would be the value add, that would be, you know, the things that would make the difference in that case, that you think maybe have been lacking in our previous models, which now will be a real asset to have in this new model.
I guess the one that comes to mind first really has to do with medication reconciliation, because we need to coordinate that, and when patients transfer from home into the emergency room or the hospital and then get discharged, there's often a change in medication, and that's a very vulnerable time in a patient's health history. And so for someone to sit down and reconcile the medications, meaning go over, you were on this before, now you're on this, do you understand why you're taking this, making sure that that medication is available. Oftentimes the hospital may discharge someone on a medication that their insurance doesn't cover, or you need to have pre-certified. So the patient arrives home, they're discharged and enthusiastic, but now panic because they can't get their medication. And so they need someone who's going to help make sure that their care is coordinated. So med reconciliation goes up to the top.
Right.
But helping the patients to schedule appointments, to overcome some obstacles, some patients in transportation,
Right.
some in receiving home care services, making sure that a nebulizer machine gets delivered on time. Because if these things don't happen, patients are going to wind up needing to keep returning to the hospital. And our goal is to keep people well.
Right.
And if you're in the hospital, you're probably not well.
Right, right. I think that will be a tremendous boon for a lot of people, because again, when you were on that production line, you were only able to really focus on the most immediate and acute problem that someone came in for. But what I'm hearing in this discussion is that you're really looking very holistically at this patient's overall health status. So they may come in for fainting or headaches or whatever their presenting symptoms may be. But as you drill down, you find out, is there domestic abuse? Is there alcohol, drug abuse going on? What else is there that really may be contributing to this? In this model, it sounds like you will actually be able to address those things very effectively.
Yes, and when I was learning to be a doctor, I think part of listening as a family doctor is really the emphasis on hearing what the patient's telling you, but thinking about what they're not able to tell you. Think about what maybe they don't want to discuss. So for instance, they can come in with a headache, and that could be because they drank a lot last night, and that could be because they were abused by a partner at home. And if you just take care of the headache, you've missed the entire underlying cause of the visit. So you need to ask the question, address it, have the rapport, and really build the trust with the patient.
Right, right. And I think, again, the message for our audience is that the more truthful and forthcoming people can be about their own history and be truthful about what really is going on with them, it gives you information that you then can respond to, and it helps to build that relationship and trust, and also helps you to help them. You know, give them services, give them a plan, give them assistance so that they won't be coming back for the same headache or whatever their presenting symptoms would be, because you're really dealing with the underlying cause, whatever that may be, depending on the condition.
And by doing that, we're really empowering the patient. And you know, I've seen very organized patients come back, and they're telling me they're due for this lab. They're very pleased because they've seen this happen with their blood sugar, and it's really a wonderful thing to watch and see. And the patient starts to realize that the locus and the focus of control is not out there, but it's inside. And to see a patient be able to take that control for their health, that's really what you want to do as a doctor. You're not wanting to be paternalistic and calling all the shots. You're trying to assist them in doing well.
Right, right. And I think that one of the things that we often did over time, and I hope this will drop out of our lexicon as healthcare providers, and that is patient compliance. That's a term that often we would use as doctors, nurses, social workers, psychologists, you name it. And when the patient, meaning you, did not follow up with what was recommended, and then you would come back over and over again with the same problem, we would say that patient is not compliant, meaning they're not following through with the prescription, the recommendation, whatever the next steps that had been told that you needed to do, you didn't do. I think that a lot of times people were not compliant because they really didn't understand completely what they were supposed to do. They didn't understand it, they didn't understand the rationale for it, or they would have simple problems, like you said, transportation. They couldn't get to that next step. So it sounds like with this team approach, using nurses in a very coordinating of care kind of way, we hope that most of those kinds of things would be addressed.
And I think another part is really to take accountability as a physician. It's not what the patient didn't understand, it's really what we didn't understand because we didn't ask or didn't even hit our radar of awareness. So when you go and do a home visit and you walk into a house and you look at the obstacles that are there, maybe even just getting in and out of the house and how the kitchen is organized and stuff, and you think, how could I possibly have expected this patient to prepare a meal or find their medication, let alone take it? Right. So it really is humbling. In a few seconds of being in someone's home, you can see what their life is like and what they need to do to overcome some of the obstacles in caring for themselves.
I can tell you as a former public health nurse, it is a wake-up call to go into people's homes because you really see where they live and how they live, and not that there's a value judgment, just the complexity of their lives and how that complexity can be very overwhelming. And so their health needs may seem like they're number one when they're in the doctor's office, but as soon as they walk through their door at home, it sinks down in terms of priorities because there's so many other things going on.
Right, and I'm not talking about just patients who live in underserved areas or anything like that. I mean, I've seen elderly patients who live on the main line in beautiful mansions, but they can't reach the dishes where they are in the cabinet. And so you really have to sometimes break it down for somebody to help them achieve the best outcome.
Right. So are you saying that home visiting will be part of this as well?
It ought to be. I mean, everybody's going to approach this differently with some, I guess, limits of what they're going to be able to do. We're very lucky that our practice is a residency program, so we're training physicians, and we really have to demonstrate the ability to provide care in all settings. So we do home visits with the residents, and we have a nurse practitioner who goes to the patient's home after they've been hospitalized to see what is happening with the patient, what other needs may have come up, and I think it definitely is an element.
Tell us about the young physicians that you're training. We all have heard that there's going to be a massive shortage of primary care physicians. So just give us a brief profile of those that are still spirited enough to want to go into this specialty, and what are you finding?
Yeah, I think that it's always been the case that the folks who go into family medicine and other primary care fields, pediatrics, internal medicine, primary care, gynecology, they have to have a fire in their belly for taking care of patients.
Right.
And that's what I see. You know, you're not going to be rich being a family doctor, but you're going to be developing relationships, you're going to be helping people, making connections, and that's what I see is the group of people coming are really interested in providing that best care.
Right, right. And what do you think is happening in the field overall? I mean, do you see that there are more people getting excited about this new model, and therefore that's drawing young students of medicine into this, or do you think that there's still going to be this shrinking number no matter what?
Yeah. I don't think we've seen the benefit yet of all these new exciting things. And right now, some of these things are a little bit of a burden to learn, both for new physicians and for older physicians who are starting to transition their practice out. I mean, it's a lot of investment to change the way your office operates and invest in an electronic record. So we've seen some more enthusiasm. Pennsylvania happens to be one of the states in the United States that has the largest number of patient-centered medical home training programs all across the country. And it's exciting to know that the residents, when they interview, ask if we are a patient-centered medical home. They want to know they'll be training at one, and when they graduate, their employers are asking, were you trained at one?
Right.
Because they are hoping that when they graduate and join their practice, they will help to transform that practice in some of these new workflows.
Right. So they're enthusiastic, and that's what you're looking for, you know, young, enthusiastic people that really can help this to steer this tidal wave of change. So I think in closing, let's summarize. I think you've given us some really good key points. Number one, just definition of terms. The medical home is not necessarily just a location, it's more of a concept. It's really more of a home, meaning all these services are bundled together and that you really have a place to go to really get the help that you are seeking in a one-stop shop kind of way.
Well, you could look at it almost as a blueprint more than a home.
Okay.
Because it is a blueprint of how to put all these pieces together.
Okay. And then I think what we're also saying is that it is a new model. The model does include having the consumer much more involved, but also having the consumer much more able to be involved because information will be more transparent. So I think that was another takeaway from this show. And then I think the third takeaway that you told us is that it's an evolving model. I mean, people are not going to necessarily go to their doctor's office next week and find out like the whole thing has changed. They're going to see this infrastructure slowly rolling out. Is that correct?
Correct. They see, in our patients, they'll say new processes, like we're giving them a visit summary sheet. What is this? And we'll explain what it is, and many are delighted that they're seeing that now. Or tell them that they could ask for prescription renewals by the computer. So they see small changes like that, and they notice that there's a difference in the way that we're interacting with them.
That's good. So I think that's really very good because it's not overwhelming. I mean, having that small incremental change. And I also heard you say you're experimenting with certain things. You're trialing them out to see how people are responding to it.
Right. I'll think of two areas that address that. We started a patient advocacy group where we're actually asking our patients, we have some representative patients, to talk with us about how they want to receive the care. What are the problems with receiving care in our office, and how they would suggest that we change. So we're going to them to ask how you want your care delivered, process-wise. And then we have group visits, which we've been doing at Bryn Mawr Family Practice, where we have a cohort of patients with a similar disease or interest, and we've been having a wellness group visit and having a nutritionist come and speak to those patients. So you see your doctor individually, and then you join the larger group and maybe have a small lecture on cholesterol or reading nutrition labels or something like that, and then you wrap up the visit. And you know, in that context, we get to spend a lot more time with our patients, educating our patients, and it's a plus for the doctor and the patient, and also the other members of our team feel very enthusiastic about being able to achieve that.
Well, it sounds great, and it sounds like you've really put a lot of work into this. I want to thank you, Dr. Joseph Greco, for being with us today and really educating us about the patient-centered medical home. I think there's a lot more to talk about with this topic, but this was really just an introduction. Thank you very much for being with us, and have a wonderful day. I hope you enjoyed our conversation today and that the information will help you in meeting your health goals. Catch this program and other conversations on the website, drnancyrn.com. Or you can write to me as well. I welcome your comments and feedback. Thank you for listening and join us again. And remember, with health, all things are possible.